Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. And welcome back. Today we have with us Kathleen Muldoon. Welcome.
Thank you for having me.
Yeah, you're most welcome. Tell us about you.
So my name is Kathleen. I am actually an anthropologist by training, and lots of us work in medical centers, medical education training sites, med schools, doing a variety of things. I actually entered this world because I know a lot about anatomy. I know a lot about comparative anatomy, gross anatomy, embryonic development, which is actually my expertise in teaching for a long time. And so because we look at the whole organism, many of us end up teaching in medical schools. So that is how I ended up in this space.
Wow, that's fantastic. And tell us a bit about your background. So where are you in the world?
So I'm currently living in Arizona, where I do a few things. I am a professor at a medical school, and I have adjunct positions at various other places. But I moved recently also into the coaching space where I work with physicians. And I feel like there's a lot of us now who work with physicians who are burning out under the current systems, especially here in the US. But actually, my attention has increasingly, especially since pandemic lockdown, really turned towards medical students and other allied health professionals, but a lot of medical students who I think we all had to reimagine our clinical learning spaces during that time when we were no longer together with each other. And I just realized how much pastoral care I was providing that maybe I wasn't exactly used to, but noticing, especially as I've been working with physicians, what a direct line it is between how we create humane clinical systems and humane clinical training environments. And so I think I'm really interested in trying to make the system better from the vantage point that I have. And so I've really leaned into that space.
That's interesting. I actually was talking to someone who was in training during the pandemic. So I was doing a lot of online training and recently had to do an online course. And it just brought back a whole lot of that isolation feeling and I'm not with my people feeling. And it was abandon this. I can't do it this way. I'm going to have to figure this out in a different way. And I'm like, fascinating.
That is really fascinating and really interesting observation that they made, right? Because so many of our current learners don't come to class. And it's almost like they're recreating their own isolated environments if we weren't curious about what it is that students want in their community and from each other and how that translates into clinical settings.
Yeah. And I noticed that isolation happens even if you're working in a busy clinic and you're seeing patient after patient, it can be very isolating. So even though you're surrounded by people, you're also still potentially working in significant isolation. And unless we're really checking in with each other, like I'll go all day without seeing a colleague and they might say goodbye as they're leaving the clinic for the day, and I have not seen them at all, not once.
I think you're also making a wonderful observation, right? Because how do we move from a system that feels very productivity based to one that's more humane and has that connection and gets people back to their why for medicine? Because I don't think anyone goes into medicine thinking it's going to be easy or thinking that it's going to be isolated. And some of the sayings that everyone uses during the admission process, why do you want to be a doctor? Because I want to help people. Those are cliches for a reason, right? They're true most of the time. So I imagine it can be very easy to feel isolated even amongst your colleagues in a busy clinical environment.
Yeah. Tell us about some of the work you do with physicians. What are you noticing about the physicians you're working with, and what are you helping them with?
So I am noticing a lot of that feeling of isolation, and I think that leads to a detachment that we are currently calling burnout. And I would say a lot of times that gets framed as a kind of exhaustion, and it is that. I also think a lot of it comes from a lack of psychological safety in the workplace and the ability to ask questions, to reimagine roles, to reconnect with, even by taking a breath, right? By with those moments that brought you to this career in the first place. So I'm seeing a lot of people who feel detached, who wonder if this is the space for them, even as they're really great at their jobs. There are people that we need to have in the field. And I say that really selfishly. I've talked about the kind of professional part of my job that brought me into this space. I've left out a bit of the personal, which is I'm also a caregiver. My mother, she has 3 children, but including one who, my middle child, Gideon, who is medically complex. So I experience the healthcare setting as both someone who produces, who trains physicians in their first 2 years, but also someone who interacts very regularly with my son's care team, which is upwards of 22 healthcare specialists, including, he's almost 13. He just got a new diagnosis a couple of months ago. I want to interact with physicians who care about my complex son and who care about themselves enough to remember why they're doing it, because I can tell the difference in the experience that we have. And so it's something that I'm seeing personally in everyday interactions, and it's what I see when physicians come to me and physicians in training, and that includes students, that includes interns, people who are moving into attending positions and wondering, why am I doing this? Which I think is a question that you hear come up quite a bit too.
Yeah, yeah. Oh, that sounds challenging. 22 people to help you look after your kiddo, and that's a lot of getting to appointments and all of the difficulties that come along with just figuring it all out and
Yeah.
trying to have to tell his story for him or him telling his story and having the time to do that, the space to do that, and an engaged human,
Yeah.
whether it be a physician or provider, to help.
And I think the key, and what I try to remind everyone of whenever I'm interacting with them, is it all comes down to staying curious. And I am an anthropologist, as I said, so I have developed my skills of observation and what we call deep hanging out, right? Which is just like sitting with people and being curious about their story, right? I see the signs on every clinic door that say, please be kind to our staff. We will not tolerate poor behavior. And I initially was extremely sad that those kinds of signs needed to be up. In addition to understanding that we are a society that seems to thrive on stress and moving in parallel instead of in connection with people, as you said, sometimes going a whole day without actually connecting to somebody. And so how do you just get curious to where that's coming from? And I don't mean that to say tolerate abuse, but I mean that I have had situations where people are barking questions at me, and it might be a high stress situation. What's his baseline? But that's a really hard question for me to answer, because the way he may present at an ER, which is similar to anybody on their worst day, or certainly not their best day, is not his baseline. So I appreciate that people are trying to get, but I could say where it's like nonverbal, non-ambulatory, but he is very communicative when he has his eye gaze communication device and loves to move when given the structures and substrates or his power wheelchair to drive it. There's not much time. I understand I'm communicating information, but can we get curious about how we do that with each other in a way that still connects to the human parts of who we are? So I think really what I try to center on, and what I see a lot of when people come to me, is being curious about, okay, so what is not working for you in this environment, or what question are you afraid to ask, or is there one moment, even at the end of the day, that you can reframe with some kind of curiosity, what is going on with that patient that, yes, interacted very poorly with you, and don't let them off the hook for that, but what can we remind ourselves that we're not always our best selves, and maybe lean into the practice of giving each other a little more benefit over the doubt.
Yeah, I really like that. I know that when we've done some cultural awareness training and, for instance, trauma-informed training, we know that the patients coming in and the what it required for them to come into a medical center, to sit in front of a doctor in a clinical environment, is projecting somebody that they aren't when they are at home in their relaxed environment.
Right.
And the ability to connect with someone when they are highly stressed or very uncomfortable about looking at someone who doesn't look anything like them, it doesn't sound anything like them, and trying to bridge that gap in a way with all the limitations we get within our clinical environments in terms of time we get with them. They have had to interact with our appointment software, our front desk staff, our MAs, and our nurses, and now they're exhausted. It's giving us that perspective, if we actually stop and think about it, that, oh, they're a little bristly around the edges. And if I wonder why about that, and I'm looking at somebody who doesn't look like me or is telling me a story of significant trauma, or like you said, you've got 22 other people who look after you. Why do I have to retell this story again? Can't you all
Right.
figure this out and communicate better? I can understand frustrations. And I love that you said stay curious. And I know that we don't have time to stay as curious as we want to stay,
Mhm.
but that makes a huge difference as to the story we're going to get from the patient and our ability to help bridge that health gap with patients. This is what I say to, we had third year students in our community, and that if you interview any of them, they will tell you, she kept saying, stay curious. It is something I tell them because I don't want to hear that Mrs. has a UTI and I want to put her on this.
Yeah.
I'm like, no, did you think wider than that? Did you expand on this or did you go narrowed straight in on that? And interesting that you
Well,
say stay curious.
let's take a step back and think about where that comes from, right? Because I think everyone, no doctor goes into training thinking it's going to be an easy path.
No.
It's not going to be, and you're signing up for hard conversations. But how are we practicing sitting in those hard conversations and knowing that you are going to be on the receiving end? It's like parenting. I cannot expect my children to come home and be their best selves all the time, right? And so, how do you bring yourself back and maybe think about what is a better question here? Yes, you may still only have 15, 20 minutes with a lot of turnover, but what is the question that gets underneath? What is the actual suffering here, right? Because what they're coming from, what they're reacting to, it might be because of the presenting condition, or it might be some other worry. How am I going to pay for this? Who's taking care of my other kids? Like all of the other things that you don't know that are part of someone's life. And another thing I always say is you won't know unless you ask. So just
Mhm.
ask the question. And I really do think that in our training environments, we focus on the one right answer. So the students presenting to that was really trying to get that multiple choice question right, which is how we evaluate. But how do we incorporate that comfortability with discomfort? And to me, keep reminding ourselves that that's what we're here for.
And it's so hard when we're getting roughed up at work, I
Yeah.
guess is a possible way to say it, when our appointment times are cut or our management is only interested in talking to us if there's something that they need to whine about to us.
Yeah. Yeah.
Go back to what you said about psychological safety, because even though we said it, it may not be understood by our audience what psychological safety means for a physician in a workspace. Do you want to touch on that first? Because I think that kind of unlocked something that I understand about myself, but I'm going to let you have a go at it first.
So, the way that I understand psychological safety is the comfort that we have in any given environment, and I tend to think of learning environments or clinical environments, to ask a question or challenge status quo or be our authentic self and not just the polished professional version, but within professional bounds, like how safe does it feel in an environment, like for example, like a learning environment? Can a student ask a professor a question about why does it work that way? Or can an intern ask an attending, can we just pause there and think about how we're centering the patient's needs, for example, right? And to receive that without experiencing it as a threat to your power or control, but really we're co-constructing really an environment here in which learning and moving forward involves questioning and pushing the boundaries of protocols or typical learning environments. And so that's, for me, something that I think is key to environments, especially ones that are structured with a hierarchical system of power, which is just embedded in medical culture.
Yeah, yeah, absolutely. I was just reflecting on places that I've either chosen to work or chosen to learn, go and train. And when I've had to choose between two spaces, it's been for psychological safety. And I always thought I was choosing them because they were friendly or approachable, but it's more than that. It's the ability to say I'm having a bad day, or its ability to say, I need this, like a second computer monitor. I need this to be able to work because it's going to make my job here easier. And so you're valued beyond just the number of patients you can see in a day. And you're listened to, and where possible, needs are met and respected, and respect towards each other within the team. So even if you're getting respect, but you're seeing your receptionist not being respected, that for me was I don't want to work here if that is the culture here. That and so when you said psychological safety, I'm like, that's fascinating that you're right. If we want to be valued as humans, listened to as what are our needs and what do we need, and also listen to others and have that engagement on a level beyond just, I'm here to pleb.
And especially, it makes sense, and you're talking about it in terms of your professional team, which may include MAs, receptionists, and I'm not sure how universal this term is, like mid-levels, right? So like nurse practitioners and physician's assistants. And oftentimes when I'm in leading workshops with medical students, and they start using these terms like mid-levels, this, whatever, I pause and I say, tell me what using those terms mean. I know you're conveying something, but let's just pause for a minute and think about what that means, because where is the power? Where is the safety? What kind of culture do you want to co-construct? And the same thing is true, as you said, if a patient comes in, how safe are you making the environment for the patient to give you the information you need to do the job? And I feel like we do need to do a better job of just paying attention to how we're doing it. And we're not always going to be perfect. It's just like anything else, it's a community of practice, right? But being open to the fact that if somebody asks you a question or asks for something you need or an accommodation, and you can receive that genuinely for what it's meant to be, which is usually just a question, right?
Yeah.
Not a
Yeah.
challenge of power.
What if we find ourselves in a place where we don't have a voice? We don't feel valued beyond the number of patients we're seeing and whether we have our charts closed in the 24 hours that is required within the system. Is that part of the work that you're doing with physicians? Because we know that the system, wider than us, or the workplace, wider than us, is as it is right now. And it's very hard to move a big and established thing, the system. So wherever we are, we're here. We found ourselves here. And it may not be to our best advantage right now. It may not be psychologically safe. Tell us, what are the sorts of things we can start to do for ourselves if we're finding ourselves in these places?
I really do believe that change comes from the middle out, and that people who are in positions of middle power or low power can exercise small ways without burning down the whole system and being that person that nobody wants to work with. What are the small ways that we can take the sign down out of the window, right, and stop going along to get along in a system that you know is not benefiting you, is not benefiting your peers or your patients, and is sending you just barreling towards burnout. I do this actually, so I'm trained in applied improvisational theater techniques. And so one of the techniques I like to use to get comfortable with uncomfortable situations, like maybe asking a question or pausing, and especially the people I work with, students, they have no power in the system. And they will push back on me so hard, Dr. Muldoon, I can't. Even if a preceptor on a site wants to call me student one instead of my name, I'm not going to push back on that. And I get where that's coming from, but it's also fear and not the system that somebody wants. Think about what we're saying. Like, you won't correct somebody. You won't just say my name is actually Sarah or whatever it is, right? So what we do is we practice improv theater. People think of makes you laugh. It's funny, but the reason why it makes you laugh is because it's people being vulnerable with each other and completely present. And the exercises were actually developed by Viola Spolin, who's considered the the grandmother of improv theater for immigrant populations in Chicago to connect with each other and to build empathy. So it's a great starting point for practicing in low stakes environments. How do I stay present and stay curious and take one step towards calling into observation what might be happening in a situation? And it's not always calling something out, right? But if somebody comes at you, we do an exercise called rant and reframe, right? So I tell people, come in with something you can just rant about for 3 to 5 minutes. I often don't put any parameters on it. It can be political, it can be like personal, it can be whatever you would like. And I hear all sorts of stories. But the exercise is that one person rants for 3 minutes uninterrupted, and the other person hears it without responding, and then practices just, I hear you and I see you, and these 1 or 2 core values is what matters to you. So it's practicing being able to hear what's under, but then we expand that out and we say, okay, so if this is happening in a scenario that's like a clinical situation, like how do you just then, even if you don't say, this is my friend Sarah and they value psychological safety in those words, but how do you, in a situation where you don't have the power, just say, I'm wondering if I can put that in my own words to see if I've understood it correctly. Or what I'm hearing is the patient needs this. Is that correct? Because there are situations where people rant or go off or don't have a lot of power. So you're not going to call in an attending and when you're a medical student and say, I think you got that wrong, or I don't think you're treating that person with enough respect. But you can remind everybody in small ways that there is a better way, because I do truly believe everybody wants to have a better system. And you're right, the system writ large is going to just keep moving like a monolith. You can't, but you can trade control for influence and have that effect on your immediate team. That's actually one of the tenets of improv theater, and know that you're making a difference for that one patient, for in my case, with these groups of students that are going to go out and practice medicine, I hope, in a very humane way. And so I do think there are ways where you just recognize, and maybe it even just starts with the journal at the end of the day, or the little notepad that you keep in your pocket about something that didn't feel right to you, and you just make a note on it. And that's called a parallel chart, right? It's not your notes that you keep on the actual patient that will be returned to them, but for yourself, like when Joe Smith said this, I felt that, right? And then you can unpack that. And that becomes also part of just recognizing I'm not okay with just getting mad at every patient now that looks like Joe Smith moving forward, right? Because our brain does weird things and it creates these heuristics that can be very harmful. But how are we moving forward in a way? I have a whole workshop series based on these kinds of exercises that bring us into greater attention that we do not always have all the power, but we sure always have influence.
Wow. I like that a lot because that can be used everywhere. It can be used towards ourselves, towards our patient. We're listening to the wine in the tea room from the whoever it is about something about the system that's really difficult to manage, and they're hearing it, but not just as the more and more negativity, but as a little bit of the what's underlying here, what are they asking for? What is it that they need? And even just validating what they're saying and or helping where you can help at that level, whatever that connection ends up looking like.
Exactly. And you might even say, are you just venting right now? Do you need to vent? Or are you looking for solutions? Do you want to workshop this?
Yeah.
Like all the time, right? And so often, especially physicians, go into fixer mode
Yeah.
because that's
Yeah.
what so many people feel like is their job. It's hard to sit with things that are not fixable. But one of my favorite quotes from Kate Bowler is that life is a chronic condition and you can't fix everything. And so just sometimes the healing within systems now I'm talking about is just pausing, observing, and saying, what is it that you need right now? What is coming through? And can you imagine on a team, a healthcare team that's centered on improving patient experiences and just checking in with each other at some regularity? I think that would be even more valuable than CEUs in some cases, right?
What is a CEU? I don't know that term.
Oh, okay. That must be in a very, like a continuing education
Oh,
unit
okay.
or credits, right? And so, or
Yes.
continuing
Yes.
medical education, CME, yeah, which end up a lot of times just being like workshop, like modules, right? Or sometimes
Yeah.
going to a conference and
Yeah.
taking your test. But I just imagine so many opportunities that we could really expand on if we just focus on the humanity of it all.
In good news, I think most of the systems that I work within, if we take a learning and we go back to our team and discuss it, that gets even more credits than the original learning. So
Yeah, well,
that's the
that's
higher value. That's the quality that actually changes and moves teams together or the systems improve. Yeah, absolutely. Okay,
mhm.
thank you for clarifying that. I'm like, oh, I better double check what that is. All right. How do you work with physicians? Are you working with them one-on-one? Are you doing workshops? What are the sorts of things that you're doing with physicians and clinicians?
It's three ways usually. So I work one-on-one with physicians that oftentimes reach out to me through referral or reading some of my work that I published in either Kevin MD or I have a Substack called Humanity in Medicine, which is I'm trying to just grow a community so that people know that they're not alone and we can practice in these low stakes environments, like what it looks like to be present to one another. I also run workshops that I'm often brought onto campus, either in like clinic based to run improv workshops, really to work towards a common goal of understanding each other, improving team function, of improving patient experience. So I've been doing that as well as developing kind of systems that are evaluative of how when people administrators recognize that they're not this they would like an evaluation of kind of how the team is functioning and really that concept of psychological safety it's a brilliant leader, right, who can recognize that their team is not functioning in the way that they want them to and they want it to be a little more humane. And those places are growing, I think, as people are recognizing the changes in the systems. And so, yeah, those three ways. I usually work one-on-one in workshops, or I'll go out to programs and do some work on site.
Yeah, I love that. So, what are some things that we haven't talked about that we should talk about?
I think sometimes, and I see this, and I was thinking about it actually before we got on the call, it's like, what is the hidden cost of professionalism and how we, both as we, and this is very interesting to me as an anthropologist, right? That there's the cultural ceremonies that we use to indoctrinate students into the process of becoming a doctor. And with the white coat ceremonies and moving through these natural high stakes moments through training, board exams, graduation, matching, like all of the things, right? Your first year of intern, graduating from your first year of residency. And I wonder, as more physicians have come to work with me, what that enculturates about professionalism that actually is masking emotional suppression, that you have to be detached over performance, hiding when you need help, hiding that you need mental health support when you're feeling burned out. And what comes at top of mind to me is self-erasure, that you have to hide yourself, the full you that comes into a space. And I really think about this because I think I was being interviewed or having a conversation with somebody, and we're talking about the different hats that I wear. And we all wear many hats. And I just thought that's not really a good analogy because it's more like I have those like an optometrist or an ophthalmologist might use to check your vision, right? It's multiple lenses that I'm constantly using all the time, no matter what space I'm in. So the questions that I ask in my classroom are the same questions that I ask in my son's care team meeting or his IEP, individualized education plan meeting for his school-based supports, or that I ask in workshops for physicians. It's not like I'm taking my hat off. I'm okay, now I'm a mom. I ask of my children. Now I'm a doctor. Now I'm this. So I wonder what these concepts of professionalism and how it comes into our idea of training to be a doctor, how it actually leads to erasing ourselves and we have to hide our true selves from our patients, and how that contributes to why doctors come seek me out in the first place, because they're burned out. So I don't know, what are your thoughts on that?
I agree. Self-erasure is a great way to describe it because really, truly, that learning how to stuff down your emotions so you can walk into the next room and not have the last patient still emanating off you is a disconnection from your humanity. And when I was coming through, I don't think we had that training in how do we even acknowledge myself and how I felt about that and let go, let that kind of calm and down a little bit some of those floating type exercises before we move into the next room. So we're just melting this stress over the day, and that's then going to flood into our ability to go to sleep at night and the deferring of work because I need to be present and empathic and do everything for this patient in this moment. So I'll defer the work of this consultation to the end of the day because clearly the 5 p.m. version of me is going to be so much better at doing this. And I clearly don't have two children at home that need me. So it's translating into decades of working in the evenings for hours and hours. That's where that self-erasure came from. And how much better engagement with the patients I see and other team members I see, it is when I'm able to be vulnerable enough to be who I am. And as a rural doc, I get this because I get to go to Walmart in my daggy Saturday clothes with no apology. I'm
Mhm.
not your doctor today. I have small children following behind me, or I'm out just grabbing the milk that I need for my
Mhm.
breakfast or whatever. And it's okay. I'm allowed to be me. And that makes life and interaction with others so much more pleasant.
And I think it alleviates your any pressure to be perfect all the time because you could also come into work on a day that you've gotten not very much sleep or there's something going on at home and just be like, I got two kids, there's a lot going on and just not getting into it, not spilling your guts to your patient, but that connection because your patient be like, oh, I know what that feels like.
Yeah, exactly. Yeah.
Yeah, they don't want to have a robot
They
for
don't want to have a robot. They don't need my whole sub story. Agree. But it's nice to have, and we know that for our cultural awareness training, that who are you and where did you come from means so much to your patients when you're able to share that with them. They need that in order to be able to proceed with the consultation. And as we learn this, oh, they need to know that I'm human too, is and remains fascinating. And of course, absolutely.
I think we can forget it, right? And also the reminder that you're asking them to disclose so much to you, so much that you can offer a little bit of your story to meet them so that they know that they're understood, right? I think that goes a long way. So it's the same thing, right? I don't hide, but I have a complicated family. In fact, I talked about our relationship to the caregiving community and the disability community locally, especially when I was teaching embryology, because people would ask me, like, how do people with this diagnosis experience this or that? And I would say, my understanding is that this part is hard and this part is understood. And I know that because I see these people every day. These are not diagnoses. These are not people that are out there. They are us.
Yeah.
And to me, that goes a long way towards building trust, allowing ourselves to not be perfect and understand that not every day is going to be our best day.
Yeah. Yeah. Though we expect that of ourselves, that we will
Right.
be at our best every day, never mind that we have had very poor sleep, it's year 20 of doing this,
Right.
whatever. I think
Right.
that part of that loss of self, that I must put on this professional face and I must be at my best every day despite everything. But we know that what's happening in your greater world comes with you to work. And for all of our colleagues, for ourselves, for our team, the studies tell us that who we are at work is also a reflection of what's going on at home. So we should be interested in what's going on for our team.
And if there was one gift of lockdown and remote learning, and is that there was no escaping the blending of home and work. And we all experienced it. And then, so this idea of just moving on back from it as if we didn't collectively experience that rupture, I think we could sit with that a little bit more.
Okay, so what I'm also hearing then is that the discipline of being professional is not, needs to be challenged. That professionalism you're coming back to. Yeah, it's a
And you do,
cost.
and sometimes there is a cost to it, and it doesn't have to be, like I said before, like burn the whole thing down, but look at how much space you're creating by going to Walmart in your Saturday clothes. Truly, like some people would call that a kind of moral courage, right? Because you have a role in the community and people will see you expecting you to be the doctor at all time. And maybe they'll see you and be like, huh, I have those pants too. And suddenly you're a little more human. And I think we can go a long way. To me, that is one way of creating psychological safety, is understanding that we learn, lead, and care for each other better when we feel safe enough to be fully human.
Yeah. Yeah, it's really important. It can be so hard to interact with a team member if they're not letting you know who they are and what's going on. Not that I need the intimate details of everything about their lives, but when there's very little exchanged, then it's hard to appreciate what stresses are you under? What do I need to consider when I'm talking to you? What do I need to factor in if you look a bit bristly today?
Right?
Because often we could start with, oh no, they don't like me. But if I don't know what's going on for you, it could totally be nothing to do with me. It could be a lot going on for you, and you're really trying to hold it together at work, and we just can't help you if that's happening, if you're sharing what's going on.
Yeah. I always start every workshop that I'm leading, and I train my students to do this. We call it appreciative inquiry. And it's, how are you showing up for the work of the group? And it's not meant to take up a half hour. You're not supposed to comment on each other's, but can you just do that so that you understand, I didn't get much sleep last night. So that if you are in the workshop a little bristly, people know it's not personal, right? And there are a lot of reasons why you cannot maybe you're up all night playing video games, or it can be something, watching a great movie, reading a good book that you can put down. But just knowing it, just framing how you're showing up. It's like a 5-second check-in. I think it can do so much.
Yeah, yeah. And part of good teams can just be that. Like you said, it's a way for us to be able to build some psychological safety within a system that doesn't necessarily feel like it cares about you. You can
Right.
do this with your teeny tiny team that you're working with today.
And make a big difference. Yes.
Make a big difference. Yeah, yeah. All right. Any pointers that we need to hear before we close up today?
I just wanted to remind your audience that sustainable medicine requires humanity and not just efficiency, right? And those small ways that we can practice them for ourselves, for our teams, for our patients, for our learners will create like reflection and connection and allow space for rest. And that's what makes good medicine possible and sustainable. So keep doing the good jobs that we're all doing, right? Every day we're making a difference.
I love that. There we go. Thank you so much for this conversation, Dr. Muldoon. It's excellent. And you all have a wonderful rest of your week and find ways to help find your humanity in your systems.
Yeah,
Yeah,
same
so
to you.
good.
Thank you so much for having me.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.